Hi guys, welcome to today's MCQ discussion. So let's get started. So the first question is from embryology, high yield topic, this one. So which of the following is formed from the Rathke's pouch? A. Anterior pituitary gland, B. Posterior pituitary gland, C. Pineal gland, and D. Hypothalamus. So we'll pause, wait for you guys to answer, then start. Okay, so this is a fairly easy question, fairly straightforward question, but a lot of people have a confusion with regard to the Rathke's pouch. So everyone knows the Rathke's pouch is associated with the formation or the embryology of the pituitary gland. So let's remove the pineal gland and let's remove the hypothalamus. So just to make things a little comfortable, here we have a diagram of the pituitary gland. We have the anterior pituitary and the posterior pituitary. And the anterior pituitary is also called the adenohypophysis and it's mainly made up of glandular tissue, whereas the posterior pituitary is basically nothing but the extension of the brain. So it's also called neurohypophysis. So adenohypophysis, the anterior pituitary, glandular, neurohypophysis is nothing but an extension of the brain. So it's also called neurohypophysis. The hormones secreted are very important. I know all of you know it, but we'll just discuss them again. So only two hormones are secreted by the posterior pituitary, and I used to remember it as ADOX. ADOX is nothing but ADH, or the antidiuretic hormone, also called vasopressin, and oxytocin. So these are the only two hormones secreted by the posterior pituitary. The anterior pituitary secretes all the other hormones. So firstly, growth hormone, then ACTH, adrenocorticotropic hormone, which helps in cortisol release, then TSH for thyroid, so thyroid stimulating hormone, your gonadotropins, the FSH and LH, and lastly it also secretes the prolactin, which helps in production of milk. So these were the different hormones secreted by the pituitary gland. So again, we don't know whether Rathke's pouch is associated with anterior or posterior. So let's discuss a little concept so that you remember this forever, and Rathke's pouch is never a difficult concept for you. So remember, the adenohypophysis or the anterior pituitary develops from the floor of the mouth, and the posterior pituitary or the neurohypophysis is an extension of the brain. So it develops from the base of the brain. So sorry, I meant roof of the mouth. So let's draw both the structures. So on top you have the base of the brain, and below here in blue you have the roof of the mouth. So this is the roof of the mouth, and the red is the base of the brain. So what essentially happens during embryological development, there is a projection which comes down from the base of the brain. Okay, this projection forms the posterior pituitary, and there is also a projection which goes up from the roof of the mouth, and this projection forms the anterior pituitary. So a few months in, you have the sella turcica forming, okay, floor of the mouth, and you have your anterior pituitary, which is the same as here, and behind it you have the posterior pituitary, which is nothing but the extension of the brain above. So this is in the sella turcica, the anterior and posterior. So this projection from which the anterior pituitary develops from the roof of the mouth is called the Rathke's pouch. Okay, so the projection from the roof of the mouth from which the anterior pituitary develops is called the Rathke's pouch. So concept is easier now, simplified. So the answer is anterior pituitary, okay, not posterior. Posterior is for just an extension of the brain. So Rathke's pouch develops or forms the anterior pituitary gland. So one more topic I would like to put. There is also a middle pituitary which lies between the two, and that mainly produces MSH, melatonin stimulating hormone. Okay, so let's go to the next question. Question number 2 is from ENT. A 45-year-old male presents with complaints of a swelling on the left side of the neck and worsening headache since the past 3 months. Since the past 1 month, he also has been having multiple episodes of sharp shock-like pain over the lower half of the left side of face, difficulty swallowing, and reduced hearing. On examination, a mass is seen in the posterior region of the left side of the neck. Okay, so you can see a mass here somewhere, yeah, just below the mastoid, mass in the posterior left of neck. What is the treatment of choice of this condition? A. Surgery, B. Radiotherapy, C. Chemotherapy, and D. Surgery followed by radiotherapy. Okay, so pause, think, little concept based question, think, and we'll discuss. Yeah, so a 45-year-old male complains of swelling on the left side of neck, okay, and worsening headache. So the first symptom was, which we have to notice, was headache with a swelling, but headache. Okay, the second thing is, since the past 1 month, he is also having sharp shock-like pain over the lower half of his face. Okay, so some facial pain in episodes. Okay, fine, lower half of the face. Then difficulty swallowing and reduced hearing. So all these together, you should only think of one thing, and that is nasopharyngeal CA. Okay, I'll tell you why. So nasopharyngeal carcinoma, the clinical features of nasopharyngeal carcinoma include a swelling, usually in the posterior part of the neck below the mastoid. Okay, second thing, most important, headache. There's a persistent headache which worsens, and why I confirmed it was because of the presence of three things, which is called the Trotter's triad. Okay, Trotter's triad. So what is the Trotter's triad? The first heading is ipsilateral trigeminal neuralgia. Ipsilateral trigeminal neuralgia, and trigeminal neuralgia presents as facial pain in bouts. Remember, trigeminal nerve supplies the sensory part of the face. It is a fifth cranial nerve. Sensory supply of the face is by the trigeminal nerve, and bouts of pain due to trigeminal nerve injury is seen in nasopharyngeal carcinoma. So nasopharyngeal carcinoma, the mass grows and damages the trigeminal nerve. So injury to trigeminal nerve leads to trigeminal neuralgia, or sometimes they say temporoparietal headache. So the first part of total triad, I saw it in this case. Secondly, difficulty swallowing. So the second concept is difficulty swallowing is indicative of palatal palsy. Okay, so that is due to injury to the 10th cranial nerve due to the growing mass. And the third is conductive deafness. Okay, so this patient also has reduced hearing. Okay, so when you see this trigeminal neuralgia like symptoms, face pain, headache, then palatal palsy, that is it presents as difficulty swallowing and hearing loss, and this hearing loss is conductive in type because there is compression of the eustachian tube by the mass. So when you see these three things together, you should immediately point to nasopharyngeal carcinoma. You have a mass, you have a male complaining of a headache, trigeminal neuralgia like symptoms, palatal palsy, and conductive hearing loss. So all this directly, very straightforward diagnosis, nasopharyngeal carcinoma, very straightforward. So we know, but that is not the question. That's just the first part of the question. The question is, what is the treatment of choice? So even they know that you can figure out from a classical history like this that it's nasopharyngeal carcinoma. They want you to answer how or what the treatment of choice of this condition is. So this is also important. Remember, treatment and choice for nasopharyngeal carcinoma is always preferred radiotherapy. Okay, so it is a highly radio sensitive condition, radio sensitive tumor. So radiotherapy is the treatment of choice. A small note, stage 1 and stage 2 you do only radiotherapy, whereas stage 3 and stage 4 you do radiotherapy with adjuvant chemotherapy. So although chemotherapy is an option here, radio and chemo never come together, so we are not even considering that. So the answer here is B, radiotherapy. No surgery is done, chemotherapy alone is not done, and surgery again not there. So radiotherapy, nasopharyngeal carcinoma, Trotter's triad. Three things to remember: Trotter's triad, radiotherapy, and nasopharyngeal carcinoma. Okay, let's go to the next question. Direct spasmolytic activity on smooth muscle is shown by which of the following antimuscarinic agents? So A, tolterodine, B, darifenacin, C, oxybutynin, D, solifenacin. So very weird question, pharmac, but fact-based question, and one of these options is frequently asked, and if you solved enough MCQs, you will know what to tick already. So 2 seconds, pause, think. Okay, so the answer very easy, very high yield topic for NEET. This drug is frequently asked, oxybutynin. Oxybutynin. So let's understand a few things here. So firstly, we know all these drugs are anti-muscarinic agents. So what do you understand by anti-muscarinic? They prevent a muscarinic activity, and muscarinic activity is nothing but the activity of ACH, which is nothing but the activity of the parasympathetic system. So first thing we need to understand is anti-muscarinic drugs reduce parasympathetic activity. So what is parasympathetic activity? Effectively, it is rest and digest phase. So the person is relaxed, you have all your digestion going on, good bowel movements, good secretions, salivary secretions are high, nasal secretions are high, there's a little bit of lacrimation, urine is being passed, stool is being passed. So basically it's a rest and digest phase. So if you give a drug which is an anti-muscarinic, this rest and digest phase is reduced. So you'll have reduced salivation, reduced lacrimation, constipation. So now coming back to the topic, oxybutynin. So oxybutynin has direct spasmolytic activity on smooth muscle, and it is an anti-muscarinic agent. So where is it best used? And this is also a question which I have read. So overactivity of bladder. So whenever you have overactivity of bladder, the drug of choice is oxybutynin. So the main indication for oxybutynin is overactive bladder. Why? Firstly, anti-muscarinic activity. So anti-muscarinic means anti-parasympathetic or parasympathetolytic, which means it will already reduce by the anti-muscarinic activity, it will reduce the activity of bladder. Secondly, it is the only anti-muscarinic with a direct spasmolytic action on the bladder. So it not only acts to reduce to reduce the parasympathetic response, but it also acts by directly weakening the muscles or having a spasmolytic activity on the muscles. So oxybutynin has a two-pronged approach in case of an overactive bladder. One is the direct smooth muscle relaxation that it causes, and the second thing is through the anti-muscarinic activity. Again, always remember, parasympathetic is to pee, so anti-parasympathetic drugs will prevent you from peeing. So in overactive bladder, this is the best drug. Again, because oxybutynin is an important question and important topic, the most important adverse effects of this drug we must discuss, and it's very easy to remember. Anything that is anti-parasympathetic or pro-sympathetic, the very important adverse effect you should always remember is xerostomia. I told you, in a parasympathetic state, we are doing all our secretions, nasal secretions, salivary secretions, all these secretions are happening in a parasympathetic state. So this thing blocks the parasympathetic activity, hence the salivary secretion will reduce, and we'll have xerostomia, which is the most important complication with regard to this drug, or adverse effect with regard to this drug. Patient has very dry mouth, finds it very difficult to swallow, and that is why they are never compliant with this drug, or rarely compliant with this drug. Other than that, few more adverse effects. I told you the bowel movements will reduce, so that you can have constipation. Again, in elderly patients, you're giving this drug, they already have constipation. You can worsen the constipation by giving this drug, and you can also have blurred vision. If you remember, if you give an anti-parasympathetic drug, you will have some dilatation of the pupils, so a lot of light going in, no accommodation, so or no pupillary correction, so you'll have some blurred vision also. So these are few important complications of this drug. We'll talk about ANS in a future video in little more detail. Before we finish, my last question: a pregnant woman is found to have excessive accumulation of amniotic fluid, nothing but polyhydramnios. So such is associated with which of the following conditions? It is associated with all of the following conditions except, so it is not associated is what we are looking for. Okay, so A, twin pregnancy, B, anencephaly, C, esophageal atresia, D, bilateral renal agenesis. So few seconds, pause, think. Okay, essentially this question is very easy to answer, very easy to understand. Just two things have to be remembered to answer this, and that is the role of the baby with regard to polyhydramnios. So firstly, option A is twin pregnancy. When you have two babies, you'll obviously have more amniotic fluid, so this is ruled out. We are looking for the option with where there is no excess amniotic fluid. So we accept. So we are looking for where there is a less amniotic fluid or no excess. Okay, So with regard to baby, two things. Baby increases amniotic fluid by excreting, primarily by urinating, okay, and baby decreases amniotic fluid by drinking it. So remember, your baby drinks or swallows the amniotic fluid and reduces its quantity, and excretes and creates its quantity. So that's how the fetus keeps the amniotic fluid in check. So let's look at each of the options now, starting from anencephaly. So in anencephaly, the baby is not swallowing. So when there is no swallowing from the baby, automatically the amniotic fluid will increase. So definitely in anencephaly there is increased amniotic fluid. So this is not the answer. So remember one more thing, in amniotic fluid the CSF content is also leaked into in anencephaly the CSF content, since there is no head or vault, is also leaked into the amniotic fluid. So anencephaly is a cause of polyhydramnios because of that. Next, esophageal atresia, which means the esophagus is not completely formed, therefore there is no swallowing. So if there is no swallowing, you will have polyhydramnios. So that is ruled out. So this must be the answer. Bilateral renal agenesis. So like I said, in renal agenesis there is reduced urinary output by the fetus. So if urinary output is reduced, the amount of amniotic fluid also reduces. Okay, so that's it for today. Good discussion. Thank you.